Immuno-oncology has really exploded over the last 6 or 7 years. And there is a tremendous amount of data that is coming in regarding how immune therapy should be used in different settings. I'm a lung cancer expert, and in lung cancer, immune therapy has become certainly perhaps the dominant treatment in lung cancer nowadays. And how to use it, whether to give it as first treatment, to give it with chemotherapy as part of first treatment, to give it to second-line treatment, and how to evaluate the patients who are most appropriate to be treated with immune therapy, and how to treat their side effects from immune therapy are all major issues that oncologists are facing now. So when they asked about the big question, I think that was mostly referring to should it be used as initial treatment? Should it be used with chemotherapy? When should it be used second line? These are all problems that we're all wrestling with right now. And there's a tremendous amount of data that's coming in from many large randomized trials with immune therapy drugs that have been developed by numerous pharmaceutical companies. So that it's a great challenge to have, because we're getting better and better treatments, better options for patients with cancer. But it is a lot for oncologists to be able to digest and understand how to interpret and act on. That becomes combined with looking at the molecular characteristics of the lung cancer to determine what patient should get molecular therapy, which patient should get chemotherapy, which patient should get immune therapy. 10 or 15 years ago, this was much simpler. But the fact that we now have effective therapies that can be personalized to a patient is an important and good problem to have now. So there was a very important trial, Keynote 24, that compared immune therapy to standard chemotherapy in advanced lung cancer. And this was in patients whose tumors had a high biomarker called PD-L1. And for those patients that had tumors with this high biomarker level, it was very clear that immune therapy was superior to chemotherapy. More patients had responses, they lived longer, they had less toxicity. So this was a clear breakthrough. There's now data emerging for several different agents looking at standard chemotherapy with or without immune therapy. And while those trials are looking positive, which is very encouraging, because that's a lot of treatment and a lot of expense with some increased toxicity, I think that we're trying to, as a field, we're trying to grapple with, is this a new standard of care that we should move to? And what is the level of evidence that we need to kind of make that move? So every cancer is going to be different in regards to immune therapy. What we're beginning to understand is that there are some cancers that do elicit an immune response and some that don't. And this is due to multiple of factors. One of the main ones is, does the cancer have numerous mutations that generate new proteins that are not normally present in the human body, so that the immune system then reacts against those proteins and attacks the cancer? So there are certain cancers like malignant melanoma, lung cancer, head and neck cancer, bladder cancer, and others where that's common. And then there are some other cancers, like many of the breast cancers, like breast cancers that are sensitive to hormonal therapy, that are positive for estrogen and progesterone receptor, or that are driven through HER2, where those tumors aren't typically highly mutated, and the immune system often does not react against those cancers, so that so far immune therapy has not been efficacious in those cancers. Whereas certain types of aggressive inflammatory breast cancer, like what we call triple negative breast cancer, is does have a high mutational load frequently, and sometimes does elicit an immune response. So that in the triple-negative breast cancer, we do think that immune therapy is promising. The message from the immune therapy field is that this is only just the beginning, that the results are exciting and are really transforming the care of immune-sensitive cancers like lung cancer and melanoma, head and neck cancers, bladder cancer, and that's only going to accelerate. And we think that the science is advancing enough that we hope to be able to take some of these what so far have been immunologically cold cancers, like many of the breast cancers, and understand the science well enough and the basic principles enough to be able to convert those cancers into immunologic hot cancers so that those cancers can also benefit from immune therapy approaches.